This lecture is about addiction, and I tend to talk about addiction in just about any class I teach. I talk about the neuroscience of addiction and biopsychology, its motivating properties in my motivation class, and of course to my introduction students. But addiction particularly is relevant to a class on learning, especially associative learning, and we're going to learn how. So addiction is a compulsive and repeated behavior that causes harm to an individual and to the people around them. Now, sometimes a way of looking at addiction is the severity of the harm that it causes. So somebody might have a very mild addiction to, let's say, alcohol. They drink, but it doesn't really disrupt their life that much, occasionally, but they still feel a compulsion to do it. But like any psychological disorder, addiction is on a spectrum, and some other people might be so overwhelmed by their addiction that they harm themselves, the people around them, they lose their job, things like that, or even often die from it. A complex psychological disorder that involves many, many things, and it's one of the reasons I talk about it on my classes. There's the neuroscience influence, genetics, environment, early childhood experiences, and of course, associative learning. So the DSM-5 talks about substance use disorder or substance-related disorder. This is related to an addiction to a chemical, such as cocaine, alcohol, nicotine. And they have a lot of standards in this book about what is the criteria for substance use disorder. Here are a few. Craving the use of the drug, wanting to stop but having difficulty or being unable to stop, taking the drug in larger and larger amounts because of tolerance but also because of the addiction, neglecting others, having problems with relationships and work and school, and of course taking the drug when it puts one's health at danger. And again, we have severity, a spectrum of this disorder. Now, the DSM subdivides addiction into alcohol use disorder, cannabis use disorder, opioid use disorder, methamphetamine use disorder. So you can see they talk about it very specifically in this diagnostic manual related to the chemical itself. Here are some risk factors. Youth. Youth is a major risk factor, and in fact, some of the most recent articles on addiction begin to talk about addiction as a developmental disorder, as one would talk about autism or ADHD. Why? Because we see addiction as a psychological disorder really developing in adolescence most often. People rarely start smoking in their late 20s, 30s. They rarely show addictive behaviors to chemicals later in life. It usually starts in adolescence. And this has a lot to do with the brain development, the impulsivity, problems with self-control, peer influence, a lot of things like this. But this is really the time when we see addictions to chemicals and behavioral addictions begin to show. Other risk factors are things like the adverse childhood experience scores. This is research ongoing by Kaiser Permanente that looks at adversities that children experiences. And the more that they experience these adversities, the more risk they are for a number of things. So they are abused as children. They live in a traumatic environment. Their parents have divorced. Things like this. And the higher they score on these adverse experiences put them at risk factor for all sorts of things: depression, anxiety, cancer, heart disease, and substance use disorder. Comorbidity with other psychological disorders. Comorbidity means that when one disorder happens, it puts them at risk for others. They happen together. So we see addiction had higher risk for people with other psychological disorders like ADHD, anxiety, generalized anxiety disorder, major depressive disorder, schizophrenia, bipolar disorder, and others. So this is a real major problem. It's a very common psychological disorder. about 47 million Americans have battled with substance use disorder in the past year. That's 16.7%. That's an incredibly high number. About 10% have struggled with alcohol use disorder in the past year. 21.5 million have substance use disorder and another diagnosable psychological disorder. Again, the comorbidity. So if you're going into this field and you're trying to, of mental health, you're going to be dealing with substance use disorder as a very common problem in your clients. It's also very deadly for some people who have substance use disorder, not only alcohol and the problems of alcohol causing accidents and liver disease and all this, but we're also seeing a big wave of overdoses related to things like opioids, and especially synthetic opioids like fentanyl, which are extremely dangerous. And you can see this massive increase. So I'm recording this lecture in 2024, and last year there was, I think, between 110 and 120,000 people in the United States who died because of overdoses, mostly related to opioids, but other things can cause death and overdose as well. Cocaine, heroin, synthetic opioids, you can see are really high on there. Oftentimes it's the combination of a psychostimulant like methamphetamine taken along with an opioid. The psychostimulant and opioid don't work well together, and we get a high rate of death. This is one of the reasons that I bought Narcan, naloxone, which blocks opioid receptors and can help people who are overdosing from an opioid. I keep it in my office. I also got some for my kids. They keep them in their apartments. You might never use them, but since it's so prevalent, it's nice to have that around. But synthetic opioids, that get a lot of press, but it's not the drug that kills the most people. The drug that kills the most people every year is nicotine and smoking. It doesn't kill them instantly. Disease, heart disease, liver disease, lung disease come about from that. Another one, second on the list, is alcohol. Alcohol is a killer. And I know we think about it as, oh, we're going to have a beer, it's no big deal. But for some people who are alcoholics, who have alcohol use disorder, remember that was about 10%, this is a deadly chemical. There was a study done back in about 2011, really before the synthetic opioids started really hitting, where they asked people who are psychiatrists to rate the harm of different drugs. Harm to the user, you can see in blue, and harm to others. And they were given a score from 0 to 80. And you can see alcohol was ranked as number 1. Then we get into some other ones. Tobacco is really high too. If you look down here at this end though, you're seeing drugs like the hallucinogens, the psychedelics like mushrooms, LSD, ecstasy, things like that. These tend not to be as harmful, but we also tend not to see addictive behaviors with these, and you really do with these at this other end. I'm not going to talk a lot about non-substance related disorders as they talk about it in the DSM. These are behavioral addictions, but these can be really devastating as well. The DSM does talk about pathological gambling. About 1% of adults have problems with gambling. That's 1 out of 100. That's quite a lot. But it's even higher for those who are young, youth, under 18. 2 to 7%. Again, very susceptible to creating addictions, and now they can get into addictions being more easily accessible in gambling online. Online gambling, online betting, even video games add components that are related to gambling. There are things like a loot box. A loot box, you're playing a game, and you can pay some money to get access to this box, and inside the box could be really cool stuff that you could have for your character or really crappy stuff, and you don't know. That's a gamble, and you pay money for it. Other things that are not in the DSM, but people really look at as problems with behavioral addictions to food, internet, phone, video games, shopping, those kinds of things. But what these behavioral addictions demonstrate is that addiction doesn't necessarily be related to chemicals. You don't need a chemical for an addiction. You can still have very disruptive behavior and take drugs out of it. And that's why we'll need to understand this stuff in terms of associative learning. Another issue that we really need to focus on is the problem of relapse. Relapse is the idea that somebody has an addiction, let's say to alcohol or nicotine or something, and they've stopped. They have sobriety. They've gone through a 12-step program, or they've got some counseling, or they've just stopped on their own. What's the chances of them going back to that addiction? Very high. Relapse is kind of the rule and not the exception. In fact, this chart kind of shows relapse is equivalent or similar to some other things like hypertension. Somebody has high blood pressure. The doctor puts them on medication, they stop eating so much bacon, they get exercise, their blood pressure goes down. What's the chances of them having high blood pressure in the future? Relapse, 50 to 70%. We see similar things with substance use disorder. Between 40 and 60% relapse. Relapse is going to help us understand addiction and the important role that associative learning plays in addiction in just a moment. Okay, so here's a little history. So opium, in terms of the history of opioids, opium is actually called an opiate because it is derived naturally from poppies. And people have been using opium, for as long as we have history, right? As long as we've been able to record that. We started seeing a derivative of that in the form of morphine in the Civil War, which was a great thing. People are having to get their legs cut off. Here is an analgesic, something that reduces pain. It's wonderful. I want to emphasize something. Some of these drugs that are analgesics are absolutely fantastic medication. If you have chronic pain, these are wonderful. These are life-saving. I mean, a real high problem with people with chronic pain is suicidality. This has helped reduce that. So we can't just throw this out and say all analgesics like this, all opioids are horrible. No, they're actually very good. And most people don't get addicted to them. In fact, I would suspect that people listening to this video have taken an opioid sometime, probably in the last couple years. Did you go and get surgery on your teeth or your wisdom teeth removed, or you had a really bad cut? You might take Tylenol with codeine. That's an opioid. And you didn't automatically get addicted to that. In fact, getting addicted to it is kind of rare, but it does happen. Okay, so now we get into after Civil War, some people were addicted to morphine, and we're like, we still need an analgesic that's not addictive, not knowing that that's not possible. So the Bayer Corporation, like Bayer aspirin, they created a new drug, an opioid that was non-addictive, and it was a hero of drugs. So they called it heroin, which meant hero. You thought heroin was a street name? Nope. Bayer Corporation. That's how they labeled it. And they sent these free samples out by mail all across the United States. And they said, give a little bit to your child when they're teething or have colic or you have a little bit of pain or you can't sleep. Take a little heroin. And it's non-addictive. And of course it was addictive. And people produced addictions to it. And in 1924, there was an act to make it illegal. And that's going to be important here in a second, that they stopped the legality of heroin. Then, in the 1990s, they started using these synthetic forms of opiates. A synthetic opiate derived in a lab, we call those opioids. OxyContin was invented very early, but it was really modified and made into time-release capsules in the 1990s, and that's an example of oxycodone. And they said oxycodone is an analgesic, stops pain, reduces pain, but it's non-addictive. Why? Because it's time released. And of course they were lying. It was terribly addictive, like other opioids can be. And then we started seeing the distribution of extremely powerful opioids called fentanyl. Now, something you might not know, you have opiates in your system. You make your own opiates. We call them endogenous opiates or endogenous and they are because they are very similar in chemical to the things that poppy makes, and they really help with our pain management and sleep and some other things. They also regulate our breathing. And all of these just hit those receptors that we make ourselves. Our own opioid receptors are activated by these drugs. Now, fentanyl has an extremely high affinity for those receptors and gives euphoria, but also can affect breathing, and that's why so many people die from this. This led to this wave called that happened where these clinics started popping up. Pain clinics. You'd go to these pain clinics and you'd say, my back hurts and OxyContin. My wrist hurts, OxyContin. And they would start giving these things out hand over fist. And people would line up around the block to get these. Some of them would get them and sell them, and things like that. Here's an interesting chart from the CDC because this was a really big problem that was then changed. So this is 2006. This is the rate of dispensaries of opioids, those per 100 people. You can see the growth, especially in the South, the incredible growth that happened. This is multi-billion-dollar industry. And then people start regulating them and saying, hey, wait, you're killing people. You're getting all these people addicted. And we started to see, about 2014, the decrease in these dispensaries that occurred because just so many people were getting addicted to this. Now, what happened is they get these pills, they get addicted to them, then the doctor says you can't have any more of them, and then they would start getting heroin off the street. We also see an attempt like in alcohol prohibition, 1920, 1933. This is where it was illegal to have alcohol. I want to talk about these ideas about illegality of alcohol or opiates and stuff, because the idea was we can stop the addiction by stopping the chemical. This is a chemical-focused idea of addiction. It is the alcohol, it is the heroin that is the cause of the addiction. And what we'll learn is that's not really the best way of thinking about addiction. Addiction is more about associative learning than it is about chemicals. So this movement into this more ideas about learning, the associative learning properties of addiction, started to show these really good papers coming out. Terry Robinson, Kent Berridge, these were the pioneers in these ideas. And they wrote some very influential papers. And I've read these papers because I'm particularly interested in this. I find this stuff fascinating. And that they wrote about this new idea about addiction. First, they said, let's look at some old theories and why they aren't good. And here's our new theory. The new theory is called the incentive sensitization theory of addiction, and we're going to get to that in a moment. So the first one is based on the idea of avoidance, negative reinforcement theory of addiction. This is right out of Skinner, right? The idea of doing a behavior, motivated to do a behavior, so that one does not get an aversive outcome. Either escaping an aversive outcome or avoiding it altogether. This is also known as the opponent process theory of addiction. The idea is drug users are driven by the need to counteract withdrawals. We go through withdrawals with alcohol and opioids, and in order to stop jonesing and hurting and throwing up, you are motivated to continue taking the drug. I think we've kind of experienced this. If you drink caffeine every morning, and most people do, what happens if it's 1 in the afternoon, you haven't had your caffeine? Well, you get a little headache and it starts reminding you to go out and get yourself a coffee. So this is how it was discussed. The negative reinforcer sustain behavior, drug seeking and drug taking, not because of the state they produce, euphoria and happiness, but because of the state they alleviate, right? So This is a motivating factor for continuing to take drugs. It's just not the best theory. What it came about was really some of the earliest work on addiction really focused on opioids and alcohol. And both of them produce pretty severe withdrawal. You can die from alcohol withdrawal syndrome if you're not taken care of and you're not hospitalized, you're not on medication. It's horrible and it lasts for days. And so that seems like a real motivating factor to alleviate those symptoms. Or maybe the other idea is to alleviate some of the aversiveness of depression or anxiety or other things. You're taking the drug not to feel good. You're taking the drug so you don't feel bad. Here's some problems. Not the best and most important theory. Sure, maybe contributing, but it doesn't really account very well for the complexity of addiction. For example, some highly addictive drugs like cocaine and nicotine, they don't produce severe withdrawals. You're not hurting. You're not throwing up. I mean, it might be that perhaps you're trying to keep from feeling sort of bad psychologically from the distress of not having the drugs anymore, but it's still kind of a weak idea. Oftentimes, patterns of drug taking don't go through this sort of take the drug, I'm feeling withdrawal, take the drug because of the withdrawal, this kind of constant maintenance. A lot of addiction can go in binges. Terrible binge drinking, or that happens for 3 days and then 5 days you're not doing it anymore, right? So a lot of drug seeking and drug taking behavior is more of a cyclical. Physical dependence, which is what's happening here. Somebody's taking these drugs and your brain chemistry is changing, and when you stop doing it, you have this terrible time of when the brain is trying to get back to normal, trying to get back to where it was. We don't see this kind of dependence as a big motivating factor in addictive behavior in animal models in the lab, like rats and monkeys, or in humans. Humans and other animals self-administer opioids even though they're not feeling withdrawal. And one way you can tell that is you give them some naloxone, some Narcan. And if they're addicted to opioids, they're going to feel that withdrawal once that Narcan gets in there, but not so much if they're not. So you can tell that the animal doesn't have that level of physical dependence, and yet the key is they're still motivated to take the drug. Some other drugs produce withdrawal, and yet they don't show the addictive pattern, right? So some antidepressants like tricyclics can produce withdrawal symptoms, but they are not addictive. So again, not the best theory. And of course, there's sort of weak subjective reporting. Craving, we're going to use this word a lot, craving, wanting, thinking about the drug, trying to get the drug, wanting to get it, really severe. That doesn't correlate real well with whether you're feeling withdrawal. You might crave the drug and want even more just after taking it, and not necessarily while withdrawing from it. Again, this is why the negative reinforcement theory has some problems. So I found this chart in a paper. Here's somebody getting an infusion of cocaine. They feel subjective rush from it. The rush goes down a little bit, and the craving comes. That's only 15 minutes later. They're not going through withdrawal at this point. And if it's cocaine, they're not really feeling that withdrawal anyway, and yet the craving is happening just shortly after taking the drug. And here's the one that I think is the biggest problem with the negative reinforcement theory. Relapse. I told you how common relapse is. So somebody, let's say, hasn't had a drink of alcohol in 6 months. They had terrible alcohol use disorder, and it's been 6 months. They aren't going through withdrawal. They aren't feeling Jones, and they're not hurting, and yet they have a high level of relapse. They might just have a little sip of beer, and suddenly they're back drinking a lot. Not because of withdrawal motivations, because of something else that we're going to get to. Okay, so the other theory is reward, the positive reinforcement theory. The idea is that people taking the drugs because it feels good, because they are rewarded, they're reinforced to do the behavior because of the good feelings they have. And this is not to alleviate the bad, but to get the good. They want that positive affective state. Or they might have an association, a Pavlovian association with about to take the drug, they feel good, right? This sort of a pleasurable feeling that they get, not only with the drug, but with any stimulant associated with the drug. And this is kind of more of an anecdote than it is really supported with research. We don't find this sort of subjective feeling of euphoria when people are holding the cigarette or holding the needle or something like that. So maybe a conditioned reinforcer, maybe not. This theory has problems too. There's no direct correlation between drugs, euphoria, and addictive potential. Nicotine doesn't produce this tremendous high, but it's terribly addictive. Sometimes opiates can produce dysphoria. In other words, it makes you feel like crap, and yet can be addictive. You don't get pleasure from it, and yet it's addictive. And this is, I think, one of the strongest cases, is that if you have an addiction and it's ruining your life, you've lost your job, you've lost your significant other, you are terribly sick, you're dangerous of hurting yourself, all that is misery. And you're going to say, yeah, but it's outweighed by the kind of feeling good that I get from the drug. No, at a conscious level, the bad outweighs the good. And people will tell you that. They'll rationalize it. And finally, we can get self-administration without the subjective sense of pleasure. We can get motivated behavior to take a drug even though the drug doesn't produce any euphoria. There was a kind of a fun study, a famous study by Lamb et al. 1991. And they had these people who used to be addicted to opiates, and they were given an opportunity to press a lever to get some morphine. The morphine was so tiny, so small amount that they couldn't determine whether it was the morphine or something else. They were told, you're going to get one of two things. You're going to get saline solution, salt water, nothing, or you're going to get a tiny, tiny bit of morphine, very, very low dose. 4 out of 5 of the participants said, I can't tell. They couldn't tell the difference between getting saline or getting morphine. They got both of them, and they couldn't tell the difference. Now, then they said, press a lever, and you're going to get one of the two of these, right? So you press a lever, and one group gets a little bit of morphine, and the other group gets a little bit of saline, right? And the group that got the morphine kept pressing the lever, press. And you ask them, why are you pressing the lever? And they're like, I don't know. What else am I going to do? I'm sitting here. I'm in this lab. Or did you get the morphine or saline? I can't tell. I'm not feeling any euphoria at all. But the saline group didn't press the lever. You say, why? Well, I don't know. I don't want to get anything. I'm just going to sit here. Again, no subjective pleasure, but yet motivating. Okay, now we get to some learning. We don't get really good responses that people say, I feel a conditioned euphoria from stimuli associated with a drug. But you do get conditioned craving. So let's get into some conditioning. So people don't report that stimuli associated with taking a drug makes them feel euphoric or happy. They don't take out a cigarette or a needle or see an alcohol bottle and say, ooh, that makes me feel good. But they do say that those stimuli make them crave it, make them want it. Let's define craving here for a moment. This isn't just a casual, ooh, I really could crave some chocolate chip ice cream. That sounds good. No, these can be invasive or intrusive thoughts you can't get out of your head. And they are highly motivating and highly rationalizing. I need to get that drug. Find a way to get it. You need to get it, get the drug, get it, want it. Can't get these thoughts out of your mind. Stimuli associated with drugs make people feel that way, not euphoric. In rats, morphine can motivate behavior and yet still can act as an unconditioned stimulus in food aversion. In other words, give an animal a little bit of cheese, inject them with morphine, they won't eat the cheese anymore because the morphine made them sick and the cheese makes them sick. And yet they'll press a lever to get morphine. So that's not liking, that's wanting. And that's really what Robinson and Berridge talked about. They talked about wanting is very different than pleasure and liking. Drug wanting is not equivalent to liking. And we need to start thinking about drugs as not this pleasure or these areas of the brain involved are pleasure centers. These are the motivation centers that are highly influenced by unconditional. These are the motivation centers that are highly influenced by conditioned stimuli. So here's the theory, the incentive sensitization theory of drug addiction. This is often called a neuroadaptationist model because the idea is that the brain changes. The brain changes with drug exposure. Repeated drug taking changes the brain, and that change lasts for a long time, and the areas of the brain that are changed are involved in wanting and craving and motivating, and not pleasure. So this area of the brain becomes, with drug exposure, hypersensitive to the drug. This area that motivates, rationalizes its behavior, becomes hypersensitive to the drug, but also to the stimuli associated with the drug. This neuroadaptation, this hypersensitivity, doesn't go away when withdrawal symptoms go away. This lasts for a very, very long time. This neural circuit is involved in wanting, not liking. Areas of the brain involved in pleasure are, maybe the cannabinoid system and the endogenous opiate system a little bit. But this area is a dopamine system, and it's not the pleasure center. It affects the incentive salience. How important are these things, these stimuli, these drugs, to your incentive to get them? And a small amount of drug may prime this area. Somebody who's without alcohol for 6 months, they have alcohol use disorder, they're at a wedding, they have a little bit of champagne. If I had a little bit of champagne, I don't like alcohol. It's not going to do anything to me. It's not going to incentivize me to do anything or motivate me. But somebody who has a former addiction, suddenly this area of the brain that motivates, that causes rational thinking and to get the drug, this area lights up like a Christmas tree. And it's overwhelming. So the area of the brain I want to talk about is called the mesolimbic dopamine system. Some people call it the mesotelencephalic dopamine system. You could read either way. And what it can do is it can promote intracranial self-stimulation. This is how this works. So this area of the brain is kind of like two systems. One's in the mesencephalon, or the midbrain. These are areas of the substantia nigra and the ventral tegmentum. And those send signals up to the forebrain, the telencephalon, the forebrain, especially to an area called the nucleus accumbens that influences the frontal lobe. If I stick an electrode in a rat anywhere along that pathway, from deep in the brain all the way up to the nucleus accumbens, and the rat can press a lever to stimulate that area, they're going to keep pressing that lever, and they're going to do nothing else. They're just going to press. This isn't the pleasure center. This is the motivation center. I've actually seen in articles people talk about the mesolimbic dopamine system as the do-it-again center. The do-it-again center. The idea is whatever made this area active, do that again. Do it again, do it again, do it again. This area is really important in survival. It's active before you eat food. It's active before sex. It's active before drinking. It gets you up in the morning. It motivates you. It's just been overtaken by drugs and certain types of behaviors. So let's take a look at this. Okay, so this is kind of a diagram of a rat brain. Here we are down in the mesencephalon. Here's the ventral tegmentum, the substantia nigra sending signals up to the nucleus accumbens up here in the forebrain. And then this is sending signals and influencing other areas of the frontal lobe. Here's another drawing of the ventral tegmentum going up to the nucleus accumbens. I just have a bunch of neat drawings here. Here's the substantia nigra sending dopamine cells up to the nucleus accumbens. Now you have to understand that the nucleus accumbens is getting influence and is influencing the frontal lobe. Now what's the job of the frontal lobe? It has many functions. But one of the functions is just organizing activity, planning and doing things, motivating to do stuff, planning it out, rationalizing it out. And so this area is hypersensitive to these drugs, and it's telling the forebrain, go do this thing. Find a way to do it, whatever you need to do to rationalize to do it. We keep talking about the unconscious influencing the conscious. And the conscious thinks, oh, I'm making all these decisions myself, but it's being highly influenced by these unconscious areas of the brain that are regulated by classical conditioning and instrumental conditioning. So here we look at the nucleus accumbens in rats, the dopamine, here's the cocaine, dopamine starts activating in the nucleus accumbens. Amphetamine, dopamine starts being active in the nucleus accumbens. Nicotine, right? Nicotine, nucleus accumbens, dopamine activity just starts soaring up compared to saline. Nicotine is terribly, terribly addictive. These effects on this system, this hypersensitivity to this motivating system, is very long lasting. While we get tolerant to other things, we get tolerant, for example, to the pleasurable effects of drugs. We even know the chemistry of how that happens. That the pleasure you might get from a drug decreases. We get tolerant to it. But other systems, like the mesolimbic dopamine system, it becomes sensitized. It reacts more than it used to the same thing. Hypersensitivity, incentive sensitization theory. It also becomes hypersensitive to motivating other drugs. So we get this sort of cross-sensitization. Addicted to one drug can promote addiction to another. The dose required to self-administer methamphetamine, how much it will take for the rat to press a lever to get it, you can decrease the methamphetamine and still get that animal motivated. In other words, it becomes less and less methamphetamine activates this motivating system. So this is reactive to the drug, but also to the stimuli associated with the drug. This motivating system, this do-it-again system, is activated not when the drug is taken, but stimuli just before or in anticipation of it. I sometimes ask my class to do this little trick. I don't know if they do it, but it's kind of fun. Here's what to get a sense of what this is happening. Think of your favorite food. I mean, the food you love that food so much. Maybe it's a chocolate bar, or maybe it's sautéed garlic and chicken, or maybe it's a big juicy apple, or something that you just love so much, right? Popcorn. You know that popcorn that's both sweet and salty? Man, I love that stuff. Take that food, prepare that food. Maybe it's Kentucky Fried Chicken and 11 herbs and spices. It smells great. And stick that on the counter in your kitchen. Prepare it. Experience the stimuli of it. The smells, the sight, whatever. And then go into the other room and sit down and try to work on your computer, or try to watch one of my lectures, or try to read, or try to watch TV. And your brain will start doing things. It will start moving your focus away from whatever you're doing into that food. And you'll start thinking about it. You can't stop thinking about it. And then you'll start thinking about this stupid thing your professor had you do. What a stupid thing. He doesn't know what he's talking about. That's the rationalization of the frontal lobe. So you can go and you can get that food. It's the same system. You've experienced that in the past. You've smelled that food in the past, and you get this high burst of activity. Now imagine a drug that is engineered literally to activate this system. It's hard to resist. So now we're getting into the idea of wanting and craving, not liking. Craving is highest just before getting the drug, not during. This is the anticipation. So seeing a needle, seeing a mirror, whatever unpleasant feelings you're having, whatever is motivating you. So you're an alcoholic, you see a bottle, or you see a crack pipe, or you see somebody smoking, or you see whatever it is, that bar you used to drink at. These stimuli are in your brain at an unconscious level. They've been associated with taking these drugs in the past, and so they start motivating this behavior. And you start rationalizing, I'm just going to have one drink. I'm going to have one cigarette. I haven't had a cigarette for 6 months. My friend's smoking, and I'm just going to have one. That's the rule. The rule is just one. No, that's not how it works. And so if you have a friend who is struggling with an addiction, to alcohol and you drink around them or you smoke around them, I mean, you are really doing a disservice to helping them in this process. So this is that associative learning part. This is classical conditioning. So ACS are these environmental cues. The US is the drug. And you can get drug responses, conditioned drug responses. And those drug responses can be different from the unconditioned response. We call it compensatory, or they can be the same. So if you have a rat and you put them in a cage, you give them amphetamine, just putting the rat in the cage makes them show amphetamine-like behavior. They get all hyper-reactive and stuff. But it's not only what the drug does, it's the motivating factors as well that can be classically conditioned. So Robinson did a study. He had people who abused cocaine. And he took physiological baseline measures of their heart rate and their skin temperature and their skin conductance, number of sweat. And then he had these people watch videos of people using cocaine. Or he had patients take like talcum powder and start breaking it up as if they were going to do cocaine. These are stimuli that are associated in the past with these people with drug taking. And he had a control group that watched other videos, and he had another group that didn't have these addictions. And what he found was, when just looking at these stimuli in those people who were former cocaine users watching those stimuli, you see all these physiological changes. Changes in heart rate, changes in skin conductance. So we know that there are conditioned responses to drugs, and you can also get conditioned responses that are motivating. Instrumental conditioning, same kind of thing. Remember Thorndike's theoretical law of effect? A stimulus connects to a response when what follows is rewarding. Think about it this way. A stimulus causes behavior when what follows activates the mesolimbic dopamine system. The stimuli cause the behavior at an unconscious level, and those are really strong motivating factors. And the needle, the bottle, the place, whatever is creating these associations to the response. The mesolimbic dopamine system is active in the presence of those stimuli, and it's going up to the frontal lobe and it's making the frontal lobe rationalize whatever it needs to do. Also, some other principles of associative learning that are important to think about here. What's really important in learning? Temporal contiguity. Use that word a bunch. Pavlov said, bring two stimuli together in temporal contiguity and they associate. The better the contiguity, the better the association. Same with Thorndike. Stimulus-response association, if what follows is rewarding, but that reward has to come pretty quickly. And so some of the most addictive drugs have the fastest reaction or action on the mesolimbic dopamine system. Smoking, snorting, that gets that chemical there very quickly. Nicotine is not just tobacco. It's not just tobacco rolled up. They have done years and years of research to say, how do we get nicotine from the tobacco to the nucleus accumbens the fastest? We have to add all these chemicals. They call them vehicles because they literally take the trip and take the nicotine to the nucleus accumbens the fastest. Same with vaping. Vaping is the same thing. Another really important thing to remember here is behavior. What did Thorndike say? In order to learn, animals must behave. We learn by doing. We can't observe and learn. We have to learn by doing. We do behaviors, trial and error. Those rewarded behaviors persist. Those that aren't rewarded don't. I can't take a rat and come into its cage every day and inject it with cocaine and make a rat addicted to cocaine or heroin. The animal has to press a lever to get that injection. It has to be involved in that behavior. So the same processes that happen with addiction happen because of associative learning principles. Now, another thing is variability and uncertainty. Oftentimes drugs that are very addictive, not all, but often, have a great deal of variability in them. And let's say you get a street drug, and that's not regulated, and sometimes the dealer gets you great stuff, and sometimes he gets you crappy stuff, and sometimes whatever he got you was nothing. There was no active ingredient. That's uncertainty. That's variability. That's a variable ratio schedule. That's a partial reinforcement. And we know how strong that is in motivating behavior. I mean, we know that with slot machines, but it's the same kind of thing. We also have the partial reinforcement extinction effect in that behaviors resist extinction that are partially reinforced. So methadone is a treatment for opioid addiction. Methadone is an opioid. It's an opioid, right? And it activates the opioid system. But what it does is you get it at the same place, the same clinic. You get the same dose. It tastes the same. There's the exact same amount. You reduce the variability, and so methadone addiction is less prevalent. Finally, we can look neurologically at these associative processes. As one example, there's an area of the brain called the dorsal striatum. And you can see here that the dorsal striatum is really close to the nucleus accumbens and the mesolimbic system. And we know that if we block the dorsal striatum activity, we don't get the self-administration. We don't get the long-term associative problems. If someone addicted to cocaine is placed in a neuroimaging machine, an fMRI, and shown a video of someone using cocaine, the dorsal striatum increases activity. However, it will not increase activity when cocaine is administered. In other words, this is that part that remembers of those associations that initiate the craving and the wanting. This isn't about the drug. This is about the anticipation of the drug. Okay, I want to end with some recommendations. I like reading about this stuff. I think addiction is a really interesting psychological behavior. I've done some research on it. So I'm going to recommend some books, because if you're going to work in the field of mental health, you will deal with addiction. This book by Maya Salvitz is a really excellent book. It came out 2017, 2018. And here's an individual who had addiction, who had severe addiction problems. And she writes about her experience. But it's not just a book to say, hey, here's an autobiography of my addiction. She takes on a behavior, her addictions that she experiences, and then she talks about the science behind why it happened. So she talks about a lot of things I talked about in this lecture. She's also a very good writer and a really interesting book. Here's another book if you're interested in recreational drug issues. This is a professor, I believe he's at Cornell, I know in New York, Carl Hart. Very controversial in a lot of ways, but he wrote a book that I found very interesting because he talked about recreational drugs, not from the perspective of all drugs are bad, all taking drugs are bad. He talked about the difference between addictive behavior and responsible recreational use of all sorts of recreational drugs. And I think he tried to present, he's a neuroscientist, he's an expert in this, and he tried to take a very objective view on recreational drugs. And finally, I'll recommend this book. This book didn't have a lot to do with addiction, but it's written by Michael Pollan, who's an excellent writer. He writes a lot about food. And what he did is he writes about hallucinogens, psychedelics, dissociative hallucinogens. And what he did is he experienced all of these. He's a professor at Berkeley, and he went around and he took magic mushrooms and LSD and even licked a toad, I think, and talked about his experiences, but then talks about the history of hallucinogens and about this renaissance in research of the possible benefits that hallucinogens might have in treatment of disorders like post-traumatic stress disorder, depression, other anxiety disorders, even substance use disorder. There might be some treatment benefit from some of these drugs. Great writer, really interesting book.